Good morning, everyone. We're just getting ready for this session that you're joining on advances in care in sickle cell disease. I want to welcome all of you on this cold winter morning, and I think you're probably happy that you're able to be joining from home where it's nice and warm. So today, we will have three different speakers, and they're going to be sharing information with you around advances in care in sickle cell disease, and you will have an opportunity to learn more about gene therapy, bone marrow transplant, and some of the other treatments. And I'm just going to introduce each of the speakers. They'll be joining as they're presenting. So today we'll have Dr. Houston joining. I'm sure that many of you will know Dr. Houston. He may be your hematologist. He is both a hematologist, a researcher, and educator. And he works here at CancerCare Manitoba, as well as at the Health Science Center and the University of Manitoba. He leads our adult hemoglobinopathy clinic and the adult bleeding disorders clinic. And nationally, he's a board member of CanHeme, the Canadian Hemoglobinopathy Association, and he's also a member of Hemophilia Clinic Directors of Canada. Very pleased to have him speaking today. Also joining with Dr. Houston is Dr. Katie Quinlan. She is a hematology fellow at the University of Manitoba. She became interested in hemoglobinopathies during her internal medicine residency and has since developed a special interest in caring for patients with sickle cell anemia. And we will also have joining during the question and answer period, Yemi Adeyemi. And some of you will know Yemi because she is a nurse in clinic and she's an expert in sickle cell disease. So we're very pleased she's going to be helping with the questions. So now it's my pleasure to invite Dr. Quinlan to share some information with you and turn the microphone over to you, Dr. Quinlan.
Thank you, Lorena. So next slide, please. So in the first half of our presentation, we will be answering the following questions. 1, how do sickle cells sickle? 2, why does sickling harm the body? What do I do if I get a pain crisis, and how can I prevent them? 3, how does hydroxyurea work? Why should you take it? And most important, why is it good to increase your dose to the maximal dose tolerated in order to get the most benefit? And lastly, we'll be touching on some of the other medications aside from hydroxyurea that are available here in Canada. So sickle cell anemia is genetic. That means it is something you are born with. Here on our slide, you can see this lovely chart that shows how much of a growth we've had in our sickle cell population here locally. So sickle cell trait is not the same as sickle cell anemia. Sickle cell trait means you only have one abnormal copy of the hemoglobin S gene. Although it's important to know you have it because you can pass it on to your children, you're not going to run into issues. You run into problems when you have sickle cell anemia, and that's when you have two copies of this gene. What happens is that this gene causes your red blood cells in exposure to low oxygen to sickle. And when they sickle, they crystallize and they become this abnormal shape. Next slide. So because they're crystallized, they don't move through the vasculature as easily as they should. And in that, they will cause vessel occlusion. Now, the problem with vessel occlusion is that it causes more cells to sickle because you're cutting off the oxygen supply to them. The other thing that happens, if we can just go back, is that because these cells are abnormal, they're also prone to being broken down in the circulation, and that is through a process known as hemolysis. That is why your red blood cells are so low with sickle cell. Next slide. So what are the symptoms you can get? Well, quite a lot, actually. Almost every organ in the body can be affected. So you can have strokes, vision loss, heart failure, lung failure, be at risk for infection because of your spleen not working. Men can have something known as priapism, which refers to a painful, very long erection that takes hours sometimes to go away. And the risk there is that you can cause permanent nerve damage, actually. You can need joint replacements because of bone damage and also get things like skin ulcers. Next slide. or the most important and the most common symptom is actually pain. So we'll go to our next slide that shows a chart from a study that was done in the United States. They looked at over 90,000 patients with sickle cell. And unfortunately, what they found was that the average survival is about 52.6 years. And that's compared to people without sickle cell who live about 76 years. Next slide. So this is, I think, a good representation of how someone with sickle cell will accumulate issues throughout their lifetime and at what stages of life certain complications are the most likely to happen. So when you're first born, you make something called fetal hemoglobin. Or rather, when you're in your mom's womb, I should say, you make something called fetal hemoglobin. And it's very good at holding on to oxygen, so it doesn't sickle. But when you're born, you start making the sickling hemoglobin and you don't make fetal hemoglobin anymore. So, because the sickling hemoglobin causes problems, people with sickle cell will start to have issues as early as a few months old. It begins with pain crises, but it can also turn into things like spleen attacks, where your spleen gets very enlarged. It eats up all the red cells and causes a really bad anemia, and also puts you at risk for severe infection. Now, this infection risk actually persists throughout life because most people with sickle cell don't have a spleen by the time they're a few years old. Another complication is known as acute chest, and that is when you get sickling in the lungs, and that can cause permanent lung damage. Now, one of the most devastating consequences of sickle cell is stroke, and that can actually happen quite early on in life when you're just a few years old. Now, other things like pregnancy concerns, miscarriages, bone damage, blindness, kidney damage needing dialysis, and heart failure, these things tend to happen later in life. But what I really want to highlight here, if we go back, is just that these terrible consequences happen later on, but the disease that's causing them to occur is present from birth. So the earlier on in life that we're intervening and starting treatment, the better. So, as I said before, pain is the most common symptom. And actually, people with sickle cell can present to hospital several times a year because of pain, and it can really be quite terrible. When you're treating this at home, it's important to rest, hydrate, take pain meds, and of course, check your temperature. If you have a fever with a temperature greater than 38.5 or chills, if you're not able to control your pain, if you can't hold down fluids, if you're short of breath or having chest pain, you need to come into hospital. So, how do I prevent a pain crisis? Well, hydroxyurea is actually one of the best tools we have available, and that is why it is recommended for everyone with sickle cell as long as they do not have a contraindication. So, as I mentioned before, when you are in your mother's womb, you make fetal hemoglobin, but you stop making that once you're born, and that's when the sickling happens. So, hydroxyurea works by tricking your body into making that fetal hemoglobin again. And when you start making the fetal hemoglobin, you sickle less. So, when you're sickling less, you'll have less pain crises, less acute chest syndrome, fewer blood transfusions, fewer hospitalizations, and better survival. So, I would just like to take a moment to dispel some common myths about hydroxyurea. The first being that it's a chemotherapy with many toxic side effects, such as hair loss. And that is actually a myth. So the second is how much or how frequently you take hydroxyurea is not important. You're going to see the same benefit regardless of your dose. And that's actually a myth as well. Because it's such an effective medication, hydroxyurea is extremely expensive, you would think. But actually, it's not. It's free. The higher your dose of hydroxyurea, the more side effects you're going to experience. That is also a myth. Hydroxyurea is a relatively new drug, and because of that, we actually don't know that much about the side effects. That is also a myth. It's been around for decades, and actually, we know quite a lot about how it works. The last is hydroxyurea cannot be used in pregnancy or breastfeeding. And this one is a little bit more complicated. It's a discussion, it's a bit of a gray area, and that's why it's important to let us know when you start family planning, because for some women, it actually makes more sense to stay on the medication. Next slide. So this was a study that was done in Africa on children, actually. And what they wanted to look at was, do you get a benefit from increasing the hydroxyurea dose beyond the standard dose? So what they did was they took one group, put them on a standard dose of hydroxyurea that didn't change. The second group, they put them on a dose that was increased every 2 months, as long as their white blood cell count and platelets were not too low. Next slide. So what we actually found was that the optimized dose group did a lot better. They had 57% less vaso-occlusive pain crises. They had 73% less acute chest, 70% less transfusions, and 79% fewer hospitalizations. So when you come into clinic and you've been on a stable dose for years and years, and now we're asking you to increase it, this is the reason why. Next slide. So if you needed more proof, here is a real life case from one of our patients in clinic. We have a lovely 18-year-old female. She has SS with a high baseline hemoglobin F, and she came from Nigeria. So we started her on hydroxyurea in December, and keep in mind, she already had a lot of fetal hemoglobin. So you would think that, she's already going to be doing pretty well. And do we really need hydroxyurea? Well, in fact, you can see that she had better hemoglobin and less hemolysis when we started the dose in December. And it got even better once we bumped it up further in March. So actually, I think this is just more proof that, again, more is always better. Next slide. So, of course, all medications have side effects, and hydroxyurea is no exception. Of course, it's actually very well tolerated for the most part. One of the more common side effects are a bluish discoloration of the nail beds. You can also get ankle ulcers, but this is very rare. Now, it's tricky because you can also have ankle ulcers just from having sickle cell. You don't need to be on hydroxyurea to get them, unfortunately. Again, you are limited on increasing your dose based on your white count and platelets because hydroxyurea can decrease this. But that's why we monitor you very closely when we're adjusting your dose. Everyone's going to get a different response. Not everyone's going to make the same amount of fetal hemoglobin. Most people get a good response, though. Sperm count can be reduced while you're on it. We believe this to be reversible. And in truth, we don't actually tell most of our male sickle cell patients to come off of their hydroxyurea when they are planning to conceive because it doesn't actually always cause problems with conception. Now, of course, this is a personal decision, but I think it's just important to mention that. And then lastly, egg cell numbers may also decrease. Next slide. So, outside of hydroxyurea, we're probably wondering now what other drugs are available. The first one I want to talk about is voxelotor. Now, this was really promising initially, but it actually was just taken off the market across the world because there was a higher than anticipated number of deaths. And the evidence actually showed that the benefits were now much outweighed by the risks. The second medication, crizanlizumab, it was also very promising. It was never available in Canada. It's available in the States, but it was actually pulled off the market a year ago in Europe because they had done newer studies that showed that it really didn't do that much better than the placebo drug. Next slide. So, L-glutamine is something that is available in Canada, fortunately. Now, interestingly, in the US of A, it is known as Endari, and there they have marketing exclusivity, meaning that they're the only ones that sell it and they can charge a enormous price for it, about $120 a day. They do not have that same marketing right here in Canada, and therefore it's not really a big incentive for them to come sell it, especially when you can buy pure L-glutamine in many bodybuilding supplement stores. So that costs on average about $46 a kilogram, which would be about a month's supply. We recommend 15 grams of powder twice daily. You can buy a little scale off of Amazon to help weigh this. And actually, if you go to the next slide, there's research to show that it helps. And anecdotally, we also have patients in our practice who are on it and say that they feel that they're having less pain episodes. So this is a study that was done in the States over a 48-week period. And to be able to qualify for the study, you had to be having at least 2 pain crises a year. Okay. And what they found was that the people who were taking L-glutamine actually had 25% less pain crises than the placebo group. Now that brings me to the end of what I wanted to talk to you guys about. I'm going to be handing the floor over now to Dr. Houston.
Thank you, Katie, for that terrific beginning of the talk, telling us about the treatments that we currently have available. And I want to talk a little bit about what is coming in the treatment of sickle cell disease, the potential for cure. Okay, so can I advance the slides, or do you have to do that? Okay, I want to give as a quick dedication memorial to Dr. Adeyemi, who was a hematologist here in Winnipeg, who was an expert in sickle cell disease, who was a wonderful colleague and friend, and also, unfortunately, a patient with sickle cell disease who succumbed to an early death, as unfortunately so many people do, and an incentive to why we need to improve treatments for this disease. So can we cure this disease? Yes, but there are caveats. So let's talk about this. There are 2 curative treatments. One is bone marrow transplant, and that's where we replace the blood-producing marrow cells from the patient with those from a healthy donor who doesn't have sickle cell disease, so making normal red cells. And the second curative approach is to do gene therapy, where we take the patient's own bone marrow stem cells, we modify them to change their gene expression, and put them back into the body so that they can now correct the sickling problem. Oops, that's not going the right way. Okay, so bone marrow transplant is also known as allogeneic hematopoietic stem cell transplant. Allogeneic means somebody else. Hematopoietic means blood-producing. Stem cell reflects that these are the sort of seeds that plant the garden of the bone marrow that grows your blood cells. So bone marrow transplantation is something we have a lot of experience with. We've been doing it for over 60 years for disorders like leukemia, but it is still a very complicated treatment with an awful lot of variables that can be adjusted, and the optimum way to do this for sickle cell disease has taken a long time to work out, and I think we're still working out. It's quite clear that this is a good treatment option for children with severe sickle cell disease, but for adults, this has so far been much less often done. In fact, in Canada, only 18 adults have ever had a transplant for sickle cell disease. So this is something that is still, we're working to figure out how to do it the best way. What are the steps in doing a bone marrow transplant? First, you have to find a donor who, of course, does not have sickle cell disease. The donor ideally is as close immunologically to the host as possible. We then have to give the patient what's called a conditioning regimen, high-dose chemotherapy to clear out the bone marrow so there's space for the donor marrow to grow. And that treatment also has to suppress the host's immune response so that the patient does not reject the marrow that we're giving them. We then give the bone marrow. Now, the term transplant kind of suggests surgery, but there's no surgery involved. This is like sprinkling seeds in a garden. We infuse them into the blood, and they know where to go. They settle in the bone marrow and start to grow. But that takes time. So you have to support the patient until that engraftment occurs and blood cells are produced. And during that time, when they really don't have a functioning bone marrow, they have a very low white count or low platelet count, they're at risk of infection and risk of bleeding, and require very hospitalized intensive support. And then we have to give immune suppression drugs to suppress the rejection of the patient by the immune system of the donor marrow. So there's an ongoing need for immune suppressive therapy. So this is just a cartoon. We collect from the donor the cells, we process them. The patient, meantime, has to undergo this high-dose chemotherapy, and then we reinfuse the stem cells into the patient. So there's a lot of variables in this, and one of the variables is, where does the donor marrow come from? the best donor marrow comes from a matched sibling, a full HLA match. So 1 in 4 of your siblings will be, by chance, a full HLA match. And that gives us the best results. But only about 1 in 6 people happens to have the good luck to have a fully matched, HLA matched sibling who doesn't have sickle cell disease. So that's great, but it's only applicable to a minority of patients. We can go to registries. There are millions of people around the world who've signed up and said, yes, I'll donate marrow if needed. But because most of those people who signed up in the marrow registries are Caucasian, and the sickle patients are generally of African descent, the background is different, the HLA types are different, and only about a third can get a donor from these registries currently. So what can we do for all the rest of those patients who don't have a donor? Well, recently there's been a big advance, which is that we've overcome the barrier of immune difference, that we can use haploidentical marrow, a marrow that is only half identical to the patient. So your parents are haploidentical to you, your children are haploidentical, 2/3 or 3/4 of your siblings are haplo or full identical. So in fact, now almost everybody can have a donor, but it is a bit more challenging to use haploidentical marrow. So not only does the marrow differ, there are different conditioning regimens, sort of from myeloablative that are very intensive chemotherapy to somewhat less, but they're all still pretty heavy-duty treatment to clear the marrow. And so all of this leads to risks. So this is a procedure that carries risk. There's a risk of what we call treatment-related mortality, that upfront period when we wiped out the bone marrow and we're waiting for the donor marrow to grow, of bleeding, of infection, of organ failure. And that risk is higher in adults than children, partly because the adults have had decades of sickling and that attrition to organ function that sickling causes. There's a risk of graft failure that the donor marrow doesn't take, and so then your patient still has sickle cell disease. And then there's a risk of a condition called graft versus host disease, this condition where the immune cells of the donor marrow attack the patient's tissues. Sometimes that's minor and not a big deal, but sometimes that is a very severe chronic illness that is not, maybe not any better than having sickle cell disease. This conditioning regimen can impair fertility, and the drugs that are used in the conditioning regimen are carcinogenic chemicals. So there is a small increase in lifetime risk of cancer of other types. So this is data from a big American study where they collected data on everybody who had had a bone marrow transplant for sickle cell disease, almost 1,000 patients, and looking at what things contributed to bad outcome being death or failure of the graft. Note that this bad outcome list doesn't actually count chronic graft versus host disease, so there'd be some other bad outcomes that aren't tabulated here. But you can see, first of all, you can see that most of the transplants were done in children. So as I say, this is something we're still learning how to do for adults, and the children do much better. You can see that the matched sibling donor gives us much better results than other donors. And the conditioning regimens, if you're fit enough to tolerate a myeloablative regimen, those seem to do the best. But these risks are significant here. Now, those data are from a few years ago, and people have been working very hard to improve this. And there was an abstract presented last December at the big hematology meeting with some very exciting results using haploidentical donors. So remember that means almost everybody can have a donor. And using a reduced intensity conditioning regimen, quite a complicated regimen, but trying to balance these issues of graft rejection, of graft versus host disease, and of toxicity. They enrolled people who were late childhood to young adulthood, most of them quite young adults, and looked at their outcomes. And in fact, they had 83% of people who could get a bone marrow transplant be cured of their sickle cell disease without any of these bad outcomes. But, there's still about 1 in 20 died from the procedure. About 1 in 20 was left with severe graft versus host disease. And almost more than 1 in 4 had some graft versus host disease that was significant, and about 1 in 15 lost their graft. So it's not perfect, but it's pretty exciting. However, it's worth noting that this study had 19 centers participating, and they were only able to enroll 54 patients, and actually only 42 of them proceeded to actually get the transplant. So they were clearly selecting their patients very carefully. And I think it's, this is really exciting. These are pretty good results, but we need to see that other centers can reproduce this. We need to find out which patients really can we do this safely in. So getting there, but not quite there yet. So can we do something more space age? Sure, we can do gene therapy, the most space age thing there is in medicine. And we can modify the patient's own genes to fix their sickle cell disease. And in fact, we can do it two completely different ways. We can do it by adding a normal beta globin gene, or we can do it by modifying the regulation of gene expression. Remember, Katie, Quinlan told you about how important hemoglobin F is at inhibiting sickling. And so this is a strategy that modifies that turning off of hemoglobin F so that it turns back on and inhibits sickling. The latter is the one that's actually just recently been approved in Canada. So that's the one I'm going to talk about. So to do this gene therapy, we have to take the patient's own blood. We mobilize the stem cells into the peripheral blood with certain medications. We collect those cells from the blood of the patient. We modify them in the laboratory to change the gene expression, and in this case, to upregulate the hemoglobin F. Meantime, we have to give the patient a very intensive myeloablative regimen to really wipe out all their marrow that is producing sickle cells. So we have to get rid of that. And then we give back the modified cells, and we see correction of the sickling condition. So this treatment, its brand name is Exa-cel, as I say, has just been approved by Health Canada. The trial that led to that approval had 43 patients, ages 12 to 35. They had to have pretty bad sickle disease, at least 2 vaso-occlusive pain crises per year for the last 2 years, but they had to not have any serious organ dysfunction. And here's what the results were. So this is the black is the total hemoglobin. So their anemia improves dramatically, and the blue is the fetal hemoglobin. So we get this dramatic increase in expression of fetal hemoglobin. So we've succeeded in turning that back on. Almost half the hemoglobin is now fetal hemoglobin. The rest is sickle hemoglobin, but there's enough fetal hemoglobin that it really impedes the sickling. And it looks like it's pretty stable out to 36 months at least. So that's as far as we have follow-up. Now, this is a plot that shows the outcomes of the patients. Each horizontal bar here represents the timeline of one patient. And this midpoint, this lined up and down the middle, is the time at which they received their gene therapy treatment. And every diamond here represents a vaso-occlusive crisis. So before their transplant, to the left of that vertical line, you see that these people had a lot of sickle cell disease and a lot of pain episodes. And to the right of that line, after they'd had the gene therapy, most of the patients had no more sickle pain episodes. They were cured. Not all, but most. So this looks extremely promising. But this also carries risks, right? This myeloablation is tough. There is a risk. Nobody in that trial died, but that's going to be a risk. The same risks of infertility and late malignancy with myeloablative treatment apply. With the gene insertion approach, there's a risk of leukemia. We don't think that's a risk with the CRISPR approach, the one that's been approved, but there might be off-target effects that are still being studied. Is that really something we need to worry about? And we aren't sure how durable the correction will be, although we do think this is curative. Compared to bone marrow transplant, the gene therapy has 2 big advantages. You don't have to find a donor. You're using the patient's own marrow, and there's no problem with graft versus host disease because there's no immune reaction. So the future for sickle cell disease, I think, looks very promising. I think we will have more drugs coming. Even though voxelotor and crizanlizumab don't seem to have panned out, more things are being explored. But meantime, we need to make best use of what we've got, hydroxyurea and L-glutamine. Transplant is improving, and the technology for transplant is getting better, and it's a good choice for children and will be an increasing choice for adults, I think. But I really do look forward to gene therapy protocols. If we can tweak it, especially if we can do myeloablation without the toxic busulfan, I think we're going to have a very exciting future for sickle patients. So just to summarize, I always like to put this in a way you can remember it. For Katie's part of the talk, a patient can get in a pickle when his red cells take shape like a sickle. The S hemoglobin that causes the problem can slow the blood flow to a trickle. When sickling causes pain crisis, it defines, one might say, what not nice is, though no panacea hydroxyurea can suppress the root cause, hemolysis. And for sickle cell, is there a cure? If we pick the right patient, sure, we can do BMT or gene therapy, but some risks they'll have to endure. So, okay, questions?
Okay, we do have some questions in the chat box. The first one is there an increased risk of sickle cell with breast cancer?
Right, so I suspect the patient's thinking, the question is backward. I suspect the question is there a risk of breast cancer with sickle cell disease? No, the sickle cell disease itself does not increase the risk of cancer. As I mentioned, with treatments like bone marrow transplant or gene therapy, because of the conditioning regimen, there may be a slight increased risk of cancers overall, but not specific to breast cancer.
Thank you. Next question. My question is, if I have a severe pain, should I go to the hospital or to the ER?
Right.
If you're having severe pain, you should definitely go to the hospital. You could also try calling our clinic, and we could potentially try seeing you in our urgent cancer care. However, depending on how bad it is, we may still tell you that you need to go to the emerge.
Right.
And
But
this is very important. If you have shortness of breath or
yeah.
chest pain, you should be going to the emergency department regardless.
Right. But we do encourage you to come to our CancerCare urgent care. We have a clinic on the first floor. Its capacity is limited, and it's only open Monday to Friday during the day. But our docs here see a lot of sickle patients and are pretty good at dealing with the pain crisis. So if you're having an episode, call Yemi or Janique. We'll see if they can get you in. We'll get you in to the urgent care clinic here. It's just nicer and it's shorter wait and so on than the urgent care and emergency rooms at the hospitals. But if you're very sick, you got to go to the hospital.
Okay. Next question. Is there any evidence of working with the family to heal intergenerational traumas that might be somehow related to this kind of cancer?
I think that's probably a misplaced question. I mean, I think sickle cell disease is a disease that has a lot of impact on people through their life, and support from family, support from colleagues, from coworkers are all very important in helping people cope.
Next question. At what age can a person with sickle cell do gene therapy?
Right. So the trial and the license for the product in Canada, even though I should make a point that even though it's licensed, that doesn't mean you can get it today, right? The centers that are going to be providing this, first of all, the provinces have to agree to pay for it and negotiate a price. You won't pay for it, but that has to be sorted out, and that's in process. And then secondly, the centers that are actually going to be doing this have to create that capacity to do it. So it isn't something we can offer today, although it is technically approved by the regulator in Canada today. the license in Canada is for age 12 and up. So the younger the better, but 12 and up.
The next question is a follow-up to that. It said you mentioned that gene therapy has been approved, correct? And that answer is yes. And it said, if so, what is the next step?
Yeah, well, the next step is the Canadian Drug Agency. This is being regulated as a drug. It's kind of goofy because it isn't really a drug, but anyway, it's regulated as a drug. And the Canadian Drug Agency, which is an agency of the provinces, that because health is a provincial responsibility, it's an agency of all the provinces together that assess new treatments that come, and they're assessing and negotiating how this is going to work and how this is going to be funded, and that's in play. And then, as I say, the centers that will actually do this have to sort of work and negotiate about how to add staff and beds and so on to do this. So there's a bit of a lag to us actually implementing that.
And what makes an ideal candidate for gene therapy?
Yeah, great question. I think somebody first of all, somebody who isn't doing great on conventional treatment. Some people do so well on hydroxyurea, they'd be, today crazy to change because some people do extremely well. Most people do pretty well. Some people don't get much benefit out of it, or the rare person who can't take it for some reason. So the person who isn't doing well with conventional treatment, the person who has kind of bad sickle disease with frequent pain episodes, with organ damage, but who isn't got too much damage yet. Before the kidney function is bad, before there's lung function is bad, would be the time to do it. And I think the younger, the better.
Next question. Is there a way to test for this sickle cell gene during pregnancy?
Yes. So we strongly encourage all couples who may be at risk to be tested before they start a family, and if both couples are carry the S gene, then we ask them to talk to the genetics counselors who can give all kinds of advice about all the strategies you can do to minimize the chance of having a child affected with sickle cell disease. But we can test if there's concern, if it's a couple that is at risk of a child with sickle cell disease. There is testing that could be done early in pregnancy to determine if the child is affected.
If I could just interject for
Yep.
a second, just because this segues well to a question I
Yeah.
see below, which was, what is the difference between sickle cell disease and trait?
Right.
That is one of the reasons why we suggest coming in if you are considering starting a family, because sickle cell trait, like I was explaining, is when you have one copy of the gene. So if you have a child with someone else who has sickle trait, you are increasing your risk of having a baby who is going to actually have sickle cell anemia. And again, the difference being sickle cell trait, you can pass it on, but you yourself are not going to be having symptoms of sickle cell. Now, if you have sickle cell anemia, that's when you run into all those problems that we were talking about. If that helps to explain the difference at all.
So basically, if two people have sickle cell trait, they have a chance of having a child with sickle cell anemia.
Right. One child in 4 will have sickle cell disease.
Is there a difference in pregnancy, like the amount of pregnancies they've had, or the chances are the same for each pregnancy?
Same for each pregnancy.
Next question, can hydroxyurea and L-glutamine be combined? And if
Yes.
so, will there be any significant difference?
Go ahead, Katie.
Just a resounding yes. In the study, they looked at people who were on hydroxyurea and people who were not. Both people, like both groups, still benefited from L-glutamine. But if you're taking hydroxyurea, we think that it actually just works better together. You're just going to get more benefit from it if L-glutamine is going to work for you.
How long does gene therapy take to work?
So as soon as the modified cells are they're reinfused, as soon as the patient engrafts, as soon as they have grown, and it's all of the new blood that is produced after the procedure is corrected blood, and so it takes a few weeks for the engraftment, but as soon as that's it's basically as soon as the procedure is done, it's better. It's not something that gets better over the years thereafter. It's
Is there an idea of the recovery period, the time frame, or how
Yeah,
long?
that's a very good question, and one I think we have to get a better feel for. This is similar to we do a procedure called autologous bone marrow transplant for a number of lymphomas and things, where similar kind of chemotherapy is given, and then we give the patient back their own bone marrow cells just to rescue them from the toxicity of the chemotherapy. Um, and people, the blood counts take several weeks to come back up, but this is tough treatment, and people do need time to just recover. You're probably not back to work and stuff for close to 6 months. It's a big hit. This is a big treatment.
Next question. In your experience, how long will it take for all the red tape for gene cell therapy to be available?
This is completely new, so it's hard to say. And it's wildly expensive, right? The list price in the United States for one of these products is 2.2 million. The other product is 3.1 million. Canadian payers are probably not going to pay that, but it's a spicy meatball, as Len Manouk would say.
Can you explain more about someone with a good fetal hemoglobin who may need an increased dose of hydroxyurea? Katie?
Yeah, I can explain that a bit. So some people with sickle cell have just by good fortune a higher amount of fetal hemoglobin. And while this isn't true for everyone, we do think that that has some protective benefit for these people. Now, the reason I wanted to show that slide in the presentation was we had that exact same thinking with this young lady and ourselves wondering would she even benefit from hydroxyurea? And I think that was really nice to include because we were able to prove yes, actually, even though she already has good fetal hemoglobin, and maybe that means she has less pain episodes per year, perhaps, but we're still able to improve the sickling, which will better her hemoglobin and also help prevent all those downstream effects of all of the organ damage that you could incur during your life.
Next question.
Hi. Hi,
Hi.
everyone. I'm so sorry.
Okay.
There are so many excellent questions, and I have to say I'm very impressed that everyone is participating and asking those questions. However, we are out of time because our person that does all the moderating behind the scenes with technology has to go into the next session. Otherwise, I'd be prepared to wait and keep going, but we can't. So I just want to reassure everybody that we have a record. We have a list of all the questions that have been asked,
Mhm.
and we will share them with Dr. Houston, Dr. Quinlan, and Yemi, and they will provide answers, and then we will share that information with whoever has asked the questions. And I believe anyone that's been in the session is my understanding. So I just want to take a moment to say a very special thank you to Dr. Houston, Dr. Quinlan, and Yemi. Um, this has really been important information, and I am very pleased to see that we had this session today. And I want to reassure everyone else that's a part of this, as patients and families, that we are looking at doing something in the future as well. So, more information to come about that. I hope you enjoy the rest of your Saturday, and I'm just very pleased as well to see there are so many promising new treatments that are coming up. So stay warm, and I'm sure we'll have something in the future. Take care.